Welcome, everybody, to our session 8 of our National Nursing Home COVID Safety Echo. It's great to see everybody on today, some familiar faces, some new names. I'm going to ask that while we have when there's not screen sharing going on, if you have a camera, if you're in a place where you can turn it on and you feel comfortable turning it on, if you would please do so. And that way we can all get to know each other a little bit better, build that community that we're really striving to do. So as usual, we are going to start with introductions. We'll introduce the Hub team, and for the rest of our participants, if you could please put your name, ideally your role, and what facility you're from in the chat, that would be wonderful. So we're going to start with Calvin, our IT support for today.
Good afternoon, everyone. My name is Calvin Martinez, and I'm with Project Echo IT. I would like to remind all of our participants, please mute themselves while they're not speaking, and you can do so on the lower left-hand corner of the screen. If you are dialed in via phone, you can dial *6 to unmute and mute yourself. Thank you, everyone.
Thanks, Calvin. And now we'll introduce our Hub team, starting with Crystal.
Good afternoon, Crystal Apodaca, NP hospitalist at University of New Mexico and one of the co-medical directors for the SECO.
Thanks, Crystal. And Cynthia Olivas.
Good afternoon, everyone. My name is Cynthia Olivas. I'm a nurse manager with Project Echo, as well as the Department of Neurology at UNM.
Okay. Christina.
Hi, everyone. I'm Christina Southey. I'm an improvement advisor working with the Institute for Healthcare Improvement.
Marissa.
Hi, everyone. Marissa Marquez. I'm coordinating this session from Echo Institute.
And I'm Ava Angeli. I'm a hospitalist at UNM and the other medical co-director of this ECHO. Thank you for putting your names in the chat. That's wonderful. I did want to just point out, I know some of you I've seen in both Tuesdays and Wednesdays session. So you're certainly not required to attend both sessions. The two sessions are on kind of parallel tracks. They're covering the same material. It's just that Wednesday's group got started earlier in the process, and so is farther ahead in the didactic topics than the Tuesday group of nursing facilities. So if you're usually in the Tuesday group, you will get to this week's topic in a few weeks as well. So you're welcome to be in both groups, but it's not required for the compensation from AHRQ. So if anybody, thanks. So if anybody else falls into that group, please, or if you're confused about it, because it is a very confusing process, please shoot a private message or public message on the chat to myself or Crystal or Marissa, and we'll be able to help you out. So with that, we will jump right in and pass it over to Christina for a follow-up from our QI session from last week.
So as a follow-up, I think we'd like to start with the poll asking you what you have been up to over the last week. Perfect. And we'll give everyone about a minute to submit their response to the poll. And Marissa, if you can just let me know when the responses stop coming in. Great. So from looking at this response, what I see is that, again, like every week, you are all, doing so much to support your staff and your residents in your homes around responding to COVID-19, which is just amazing to see, and not a surprise given how we've gotten to know you over the last number of weeks. And specifically, we see that 2 of you are saying that you've made a small change that will help your facility respond to COVID. And 7 of you are saying that you're working on a change opportunity with a team. So I would like to open up the phone lines and see if either those 2 that said they made a small change would share with us what you've been up to, or someone from the 7 that are working with a change opportunity with a team. We'd love to hear more about what you've been doing. So please come off mute and share what you can.
Well, this is Susan, and I'm with the group that said I'm working with the group. What we have done now, because at the moment, we have no COVID positive in the facility. We went from 26 at our highest to 0. We are now making the plan for if we become positive again, where is the new unit located, and all of those things to quickly mobilize setting it up. So we are developing that smaller plan now. Hopefully it won't have to go to an entire unit again. The other thing we've been spending a lot of time on in our morning interdisciplinary team meeting is how do you support all the people that are working really hard. Our nursing group that ran that COVID unit for over 40 days still is struggling with fatigue, struggling with, oh my goodness, epidemiology says if we have another COVID positive patient, we have to move them down here. So we're trying to come up with some strategies to help support them in maybe the not traditional ways. We have given them thank you notes. We have given them cake. We have given them food. We have given them meetings. We have given them positive text messages. But sometimes you have to think outside your box because the pandemic goes on so long. So we're working on some of those recognition strategies as well.
So Susan, can I ask you as a follow-up? And thank you for sharing that. 2 really interesting. I'm actually going to ask you about both of them. So I'm going to ask for forgiveness already. Can I ask you, how are you finding out about some of the strategies that staff might find helpful or that you want to use to show your support and hear what's important to them? How are you sort of connecting and finding out what might work?
Well, I, as the director of nursing, can easily go down. I try to spend time down there and watch them. I have 44 years of nursing experience in management and leadership. So really connecting with them and watching them, they will let you know, some let you know verbally. Some people don't like to be recognized. So you have to watch them for a period of time. And I also talk a lot with therapy because all of our residents that were COVID positive are now on skilled services. So I talk to therapy a lot, housekeeping, all the people that now have easy access to that unit. And they don't eat all the candy.
What I like
they don't want candy and food anymore. No, they are done.
One of the things that I loved about what you just shared is that, you know, what you were saying was that really finding out what is meaningful to the staff person. How would that staff person like for us to convey how much we care about them and how important their work has been, and the recognition that that is different for every staff person. And it sometimes can take a little bit of work, right, to figure out what that is for them so that they feel seen and heard. And I think like using those different skills around, some around observation, some is around talking to them, some is just your gut from your, you know, years of experience in the field, is really just a really great example of trying to, it's like how we say our residents deserve, you know, individually centered care, and it's extending the same approach to our staff, which is, I think, kudos to you. That's fantastic. And the other thing, so let me ask you, so this plan for response for a COVID positive section, I guess, within your facility.
Sure.
How are you going about sort of sketching that out and testing out the strategies that you think you want to use in the future?
Well, we've worked a lot with epidemiology, and we follow what they tell us, because once we became COVID positive, we had weekly meetings with them. And the CEO presented the layout of the facility. So we were all already working on forward-looking places where we might place that unit. And we actually had 2. But epidemiology, because the east unit of ours has been positive, all except 2 residents, they said, stay down there. And we actually have a 4-bed ward and a semi-private that can easily be walled off again. And then we've just looked at, if cases increase, moving that wall up that hallway.
And have you done any sort of simulation or testing yet to see, should, if and when this might, hopefully it doesn't, but if this situation comes available,
Right.
is there a way to like simulate what that might be like, go through sort of the different decision points and how you might be able to do that?
Well, actually, we had to do it. Our assisted living, I manage a 20-room assisted living as well. I sent a resident to the hospital back last Thursday, and even though we had tested her both PCR and rapid, she was negative. Our local hospital tested her as positive. She didn't have any symptoms that were COVID related to me, but all of a sudden I knew she was coming back. So we quickly put together that 2-bedroom in the course of probably 45 minutes. We had an actual role play. It wasn't really role play. And we mobilized, everybody knew what they needed. PPE had already been put down there. So we had an actual scenario. We have tested her here at the facility. She has been negative for us 4 times, but we decided to keep her quarantine down there just to continue living that out a little bit longer. Once her quarantine is over, she'll go back to assisted living, but we've actually been through that small unit build already.
Oh, cool. And did you learn anything from that first test around what went well and maybe what you would do differently if you had to do it again?
Yes, we did. We learned when we first put that room together, we did not build in the small ante room. So we had to quickly go back, remind our maintenance department, we needed 2 zipper doors, not 1. And as of yesterday, we were working through with the laundry some issues still. How does that laundry get out there? How does it get down to the laundry? What's the best way of laundering one person's potential COVID laundry? So we've already been through those scenarios again. Yes.
Awesome. And last question
Mhm.
for the extra prize money, Susan.
Okay. No candy.
Have you written down these processes somewhere so that like all staff who might need to know are able to reflect on them?
Actually, the CEO started writing down, we have an action plan, yes. And I will say that one of the ECHO seminars that I was on yesterday morning, it's a 30-minute infection control one. No, they had an action plan that was the same format that we use. So we have just used our entire process on an action plan, and we update it all the time, and it's available. And if you need it, you get it out for staff, or you can quickly replicate in a slide form what would need to go to staff, yes.
Great. So thank you for that. Thanks for being on the hot seat for like a whole 15 minutes. I appreciate it.
I'm a talker, I'm good.
So I want to pull out a few threads from that, because I think you provided a really great example. One, you said early on when you were sharing about this, about how you had a plan for not only sort of the smaller unit, but how you would expand it if you needed. So I could see how you had sort of this phased approach, and you would already plan for, okay, here's the scenario for 2 people, here's the scenario for 4, 6, you hope you don't get there, but at least you're not caught off guard, which I think is fantastic, and likely a reflection of what you've learned already in your experiences in the pandemic. You had a way to be able to test that sort of naturally by what came up and learn from that and document it. So importantly, you'd be able to reflect on that, and everyone can reflect on that when they need to. So I think that's really sort of some fantastic examples of some of those core processes that we would encourage in quality improvement. So thank you.
You're welcome, thank you.
We have another minute or two if there's someone else that might be able to share an example of something that they're working on, either a small change that they've made or something they're working on with a team.
Hi, it's Jennifer
Hi, Jennifer.
Roach.
Hi.
Hi. One thing that we are starting to work on as a team, our nursing home is also connected onto a small hospital, and we have now had an employee death from COVID. So one of the things we are working as a team for both the hospital and the nursing home is bringing counselors in from EAP to see how we can give that support. I mean, we support each other, but maybe there's an opportunity and a staff may want to be with, it's just easier to talk to a counselor sometime. So we're working on bringing someone in, and we're going to see how that works. We hope to bring someone in as opposed to doing electronic, but we may also have to do a televisit. So we're going to see how that goes and see how staff respond. And I'm sure that not only will it be a response from this particular employee, but others have expressed other deaths in their lives from COVID. So, we're working on that.
I'm so sorry to hear about that, Jennifer.
Yeah.
Thank you for sharing that, and my condolences to you and all of the staff members at your site and your hospital. It must be very hard.
Thank you. Yeah.
What are you, from this process that you're going through, and feel free to sort of pass, is there anything that you think that might be useful for other facilities to know around how to be able to navigate the situation if it comes up for them?
I think for us, I mean, this is all new. It just happened yesterday. I think we'll need to look at communication and how we let staff know that this has happened, just to support them. I find, as things move on their own, as word spreads on its own on what happened, the stories can change at times, right? So how do we help staff feel informed and not, why did I hear this from somebody in another town or whatever? So I think that is something we'll have to look at. How do you communicate? How do you do it respectfully to both the staff member who passed and their family and the staff who are still here? So we'll be working on that. So if anyone has a way that they've done that, it'd be great to hear.
Thank you, Jennifer. Thanks for sharing that. And I would like to sort of open it up and see if there is anybody who can share with Jennifer if there's some strategies that you've used in a similar situation that she might be able to use at this time.
Well, I guess I have to say I'm glad to hear that there aren't a lot of people in the same situation. So I'm grateful for that. So thank you.
I'm sorry, this is Cynthia from Clayton. We've had positive staff members and we have not lost any of those so far. So my condolences, but our director of nursing will pull meeting. So have everybody come in and just let everybody know what's going on at that one time. That helps any.
Thank you, Cynthia.
Thank you. I appreciate it.
And if there's any other sort of strategies or ways that you've helped with that communication, you can always place them in the chat or sort of share them afterwards, and we can pass those along. And thank you, Jennifer, for sharing and for being willing to share that with us today. It's very hard, and our hearts go out to you.
Thank you.
I am going to pass it over to Crystal, who is going to talk to us a bit about the next section for today.
Thanks, Christina. Let's see, before I dive into, we're going to do our didactic next. And before I dive into that, just a couple of things, housekeeping stuff. Please don't forget to fill out your compensation packet. Marissa's going to put that down in the chat. If you have any questions in regards to that, if you wouldn't mind shooting an email to this address, she's also going to put in the chat for clarification. And then I also, I appreciate this group so much and how open you are with us and with each other, and how you help us learn and help each other learn. Like, it's amazing. And we recognize right now in New Mexico, nursing facilities are hit so hard with this, as hard, if not harder than the hospitals. And so thank you guys for hanging in there and coming with us, spending your time with us as well. And lastly, I would like to give the people who are on the phone an opportunity to introduce themselves. So I have a 505-629 number. If you wouldn't mind hitting *6 and just let us know your name and which facility you're from and your role.
I know you can't see my picture, but hi, I just spoke. I'm Jennifer Roach, and I'm the administrator at Memories Memorial Nursing Home in Deming, New Mexico.
Thank you, Jennifer. You must be coming up on both here. Thank you. And then there is a 564-999 number. And it's *6 to unmute. All right, if that's not working for you, just when you're able to, *6, unmute, and let us know who you are, okay? I am going to, so our didactic today, it's a bit of a heavy day. It's a bit of a heavy day. We're gonna be talking about social isolation during a pandemic and after. And so it is a bit of a lengthy video. We're gonna show a portion of it because it's wonderful. I am going to give kind of a brief, we'll show the video here in a minute, Calvin, sorry. I'm going to share my screen and go over the kind of intro to this portion of the video. And maybe I am. And then we'll get into the video and go from there. One moment, please. There we go. No. Okay. So this didactic is from Paige Hector, and you'll get to hear her voice during the video. All right. So curious about the nature of the problem. So we have kind of, we need to figure out what's going on for our residents and our staff in order to get to the meat of it and cover it. So social isolation, I don't have to tell you all that your residents are facing increased social isolation, even more than previous, because of the pandemic and rules on visitation. And there are many challenges, right, that have come with this social isolation on top of a pandemic. And then also feeling the things that are happening with our staff, right? Our patients are sicker. Reimbursement is never great, but it's not any better right now. High staff turnover, quality of care, and then feeling discouraged and demotivated, right? You're doing the best you can, and yet media reports, negative processes, all focusing on mistakes and not on all the great things that are happening. And so I don't have to tell you this either, right? Individually, we don't have the bandwidth to address all of this, right? But together, we can still affect change. So on the micro level, with your residents, your families, individual, and what we are going through is a pandemic is a trauma. It's a traumatic event that we're all living through together. So screening for trauma by staff and by providers, and then referring people to assessment and treatment when necessary. And as a facility, can be committed to operationalizing trauma-informed care, and being able to collaborate, and very much, as Jennifer shared, the bringing in counselor for this trauma-informed care. So you guys are already doing these things. So what is emotional and psychological trauma, right? You don't have to go to war to have post-traumatic stress disorder. And a pandemic is a traumatic event. So extraordinarily stressful events shatter our sense of security, feel helpless in a dangerous world. You're feeling overwhelmed, isolated. And that situation can also result in trauma, even if it doesn't harm you physically. And the more frightened and helpless you feel, the more likely you are to be traumatized. And I know for me, this rings true, right? Because there are a lot of things that I can't do to affect a pandemic. And I imagine that's similar for you, your staff, your residents. So Dr. Vanderkolk, which is amazing. If you've never read The Body Keeps the Score, it's a great book. And it's not all medical jargon, it's very well written. But he talks about post-traumatic stress disorder and how your body responds to it. And so the virus is a pre-traumatic condition with two core variables: immobilization, so we can't move, right? We're stuck. Quarantine, shelter in place, and unpredictability. We have no idea. We have no idea what's going to happen. And I think this past week/month has been really telling of that. So when the world's unpredictable and you can't move, then the vulnerability to become traumatized is exponential. And this is probably not a new concept, but we know that social isolation is different from loneliness, right? You can be alone and not feel lonely. You can be in a crowd and feel lonely. Those are two different things. So loneliness is a subjective feeling, whereas social isolation is objective. So it's physical separation. And they can exist together, but they can also exist independently. So losing a sense of connection and community changes somebody's perception of the world, right? They feel threatened, mistrustful, and that can trigger our biological defense mechanisms to trauma, which are our fight, flight, freeze. And I'm sure we all remember these. So when faced with a situation, if you are able to be strong enough to overcome it, then your body goes to the fight. If you're able to escape, then you go to flight. If you are not able to overcome it and you are not able to escape, then you go to freeze, which can look a lot like dissociation, checking out, those kinds of things. So we need to identify people who are most prone to suffer from social isolation and loneliness are the ones who would benefit most from interventions, right? And this is from Dr. Penderson. Interventions for social isolation may look very different from interventions for those who feel lonely, okay? And that's something important to keep in the back of your mind. We know that people who feel lonely and people who are socially isolated have increase in physical issues, hypertension, heart disease, anxiety, cognitive decline, Alzheimer's, depression, death, all these things. So it's a real deal that needs intervention. And there is such a thing as touch starvation, where your skin hungers for physical touch. And it can, if you are in this state long enough, it can lead to post-traumatic stress disorder. And it also has effect physiologically, heart rate, blood pressure, muscle tension, digestive system, all of these things. So when we are able to touch, hug, hold people again, will these negative isolations of negative effects of isolation, touch starvation just disappear? I'm going to let Paige take it from here in the video portion.
Associated with the pandemic. He makes the analogy of a natural disaster after which we see increased morbidity and mortality, depression, anxiety, suicide. All of these things happen after natural disasters. The pandemic is no exception. The pandemic still can see increases in all of these. And I'd like us to think, as the weeks and months go on, years perhaps, the people that we receive that come to be with us for post-acute care or to live in nursing homes could actually be suffering from these as well. He talks about there's a predictable second wave of death after exposure to mass trauma. So knowing all of this, what do we do today? How do we mitigate the effects of trauma and social isolation? Well, one of the things, if you're not already doing, is screening for trauma. This is a screening tool I personally recommend, but the National Work Group of Trauma-Informed Care that I've been participating in for a couple of years, this is probably the one that I think most of my colleagues would recommend as well. It's the Primary Care PTSD Screen. It's a 5-question questionnaire, and this is a screen, folks. It is not an assessment. So when we screen residents and they come up that it's indicated that, yes, they're experiencing trauma, the next step is we have to have a plan in place to do a further assessment, to get treatment plan in place. So we need to be intentional about these sorts of tools, that if we begin doing any kind of screening, we have to know what comes next. We have to have follow-up action steps, protocols, and policies. The same with this tool. This is a tool a colleague of mine, courtesy of Dr. Barbara Ganzel. It's a supplement to the tool I just showed you. So basically what this one does, it's looking at the current symptoms, the signs and symptoms of post-traumatic stress according to these categories. So look there on the left, it's possible delayed emotional reactions, physical, cognitive, behavioral, and existential. So as we consider how do we talk about these things, what do we do as staff? How do we incorporate this into our clinical operations, our day-to-day work? One of the things you can do is copy and paste this and create a worksheet out of it. It can be used as a direct screening tool where we talk with residents and ask if they're experiencing any of these things, because not all of these things are on that other tool I just showed you, the PC PTSD-5. So this is a supplement. It can be used as an indirect screening tool as well. If you notice there on the right-hand side where it says source. So if the resident is not cognitively capable of answering these questions, perhaps a staff member or eventually families can be able to help. But again, please don't introduce something like this until we have training in place. We know what we're going to do with this information. Where will it be housed? how does it incorporate into the care plan? So we have to work it into our workflow. We need to be talking about the unmet needs. We need to be asking residents about this. I also believe that staff, my work is a lot with staff now as well. So considering the unmet needs and incorporating this again into our work and our clinical and discussions generally speaking about residents and what they're experiencing. So here's one of my favorite resources lately. This is from the cupofempathy.com. The creator of this tool is Marianne Van Dyke. She is a nonviolent communication expert and trainer. This is a free download. Go to that website, you can get it. If you'll notice this side here, it says needs. So as human beings, we all have all of these needs and all of these categories. On the back side of this tool are these categories. So notice on the left, the first three columns are feelings when my needs are fulfilled. On the right, you'll notice the little orange or yellowish colored line at the top. These are the feelings when my needs are not fulfilled. So think about the residents in your facility right now. If their needs are not fulfilled, are they feeling pain, wretched, lonely, hurt, hopeless, powerlessness, panic, overwhelmed, irritable, anxious, startled? Look at all of those on the right. Now, when they are fulfilled, are they feeling amused, joyous, open-hearted, bright, calm, refreshed? So it gives us the words around, like that little guy in the beginning, the curiosity part. This is the languaging around the unmet needs, the emotions that maybe many of us didn't have training in the beginnings of our careers. Social isolation needs to be included in ongoing disaster planning. This was a huge point that I've been making lately, that the distress of the pandemic, it isn't going to just stop when the pandemic ends, whatever it looks like in the next year or whenever. I don't even know the time frame. So we need to be adopting and sustaining a culture of trauma-informed care, of which looking at the experience of social isolation and loneliness is part of it. So we need to be problem solving as we re-enter community life, community or life as usual. What might be some issues and challenges? The lingering effects of these sorts of traumatic experiences and the fears. What do we need to be prepared for? I will always try to incorporate things into a lens of process improvement, not just performance, but process improvement. The tasks, the things that we do day to day. So process improvement around trauma-informed care. I'd love to see task forces in each of the facilities, and it's not just one person or department. It includes lots of different people, lots of departments, families, of course, and residents. One idea could be around the video technology, video calls. So obviously most facilities are.
Thank you, Calvin. Because Christina is going to cover this process improvement much more applicable than just the general one. I do want to share with you one last slide that Paige has in here. And of course, you'll be able to access this entire PowerPoint and access the entire video. And Marissa will put that down in the chat for you. But I want to share. One moment, please. There we go. So one last slide that she has in here is by this Mickey Scott Bay Jones, who is referred to as the Justice Doula. And she has this poem, which is an invitation to a brave space. And so Paige kind of talks about it in the video as in, there probably is no such thing as a safe space, right, in these times, but there can be a brave space. And so I will just read it, it's pretty short. Together we will create a brave space because there's no such thing as a safe space. We exist in the real world. We all carry scars and we have all caused wounds. In this space, we seek to turn down the volume of the outside world. We amplify voices that fight to be heard elsewhere. We call each other to more truth and love. We have the right to start somewhere and continue to grow. We have the responsibility to examine what we think we know. We will not be perfect. This space will not be perfect. It will not always be what we wish it to be, but it will be our brave space together, and we will work on it side by side. And so in that we're in this together. And so with that, I will stop sharing my screen. I do want to, there was a portion in talking about the PTSD screen for both residents and for staff. And then that is just a screening tool she mentioned. And if that's positive, what the follow-up would be. So she said you need to ensure proper follow-up. So for residents, it would be a referral for a psychological evaluation for PTSD. And if in your staff, you have a screening tool that is positive for possible PTSD, then referral to EAP would be the next step. So I just wanted to clarify that. You maybe already knew that, but just in case. I talked a lot. I want to pause and see if anyone has any questions, comments, anything they'd like to share at all. So, and that's okay. It was a lot to take in, a lot to process. What I'd like to do, we don't have a formal case or dilemma presentation for today brought by the participants, but here in just a couple of minutes, I think that we're gonna do our breakout group, and maybe in a smaller group, be able to discuss a few things and bring it back to the larger group. And so Calvin's gonna work on getting us into breakout rooms, and we'll spend about, let me look, what time is it? I think we will spend probably about until 10 minutes, 10 to 12 minutes in those rooms discussing, and then bring it back to the big group. Avinash?
I'm gonna create the rooms right now, and I'll send everyone in there, and then I'll adjust the 3 people that need to be in each 3 groups.
Thank you. Avinash, you raised your hand. Feel free to unmute yourself.
Yeah, this is Avinash. My question is, you explained PTSD and all. I had this experience in earlier year, few months back. We all know about the PTSDs and tried approach and all, but when it comes to the personally, I'm not able to follow these things. When during the counseling, I use these things to patients, but when it comes to me, it was very difficult to apply on me. So why it is, I don't know, maybe because of my age or my mind, or what is it?
I think that's a great question, and I think it probably doesn't have just one answer. It's probably a combination of things. I think in general, it's easier to treat others than treat yourself, right? It's really hard to look that close in the mirror, right? To apply those things and recognize them in yourself. But I would say, Avinash, that you even recognize that you have a hard time doing that is huge, huge, very self-inflective. And so just as you're kind to your patients, just as you're kind to your other people, be kind to yourself, because it's a process, man. It's a process. I don't know if that was helpful, but.
Yeah, I agree. Thank you, ma'am.
Okay, you bet. You will shortly be put into our breakout groups, and we'll reconvene at 3:25. Calvin's working on it.
I'm gonna open the groups up right now.
Cool.
I'm sorry that they just sprung up breakout rooms on me.
No, you're fine. I had to just do it real quick. It's not that hard.
Well, because they talked about it in the pre-session meeting, and I was like, okay, well, if you're going to do it, like, you need to give me a couple minutes heads up. Nope, that was her heads up in the, out loud. Hey, Isabel.
Thank you. Last time I felt kind of awkward because I was just sitting there and like I was like I don't have anything to say.
Yeah, he put them. I mean, you don't ever have to stay in them if you don't want to, but he would just puts them together randomly. So all the Echo staff go in, but I don't need to be in there either. So it's fine.
I was gonna explain to them too that I was just gonna step out because I'm like an employee, and but then I was like, no, I'm just gonna go because then they started talking, so I was like, I'm just gonna get out of here.
Just leave. So let's see. I got the registration report, so I'm adding them into iEcho now. So hopefully we can just be done at the end of this. Okay. So yeah, hopefully that's good to go. And then you're doing the other one, right?
I just finished with all of the ones with the new info, and then I guess I'm just gonna save it. Do you think I should just delete the ones that we don't have to go back and fix, and then just put it back in, like update the file that's on there already? You know how it says it's like titled updates needed list. So I'm just gonna like upload a new file for that, take out the ones that are good, and then we'll just have names that who is missing information.
Yeah, we can do that. Have I showed you how to do like updating a file through Box so you don't have to keep downloading and uploading?
No, but
Okay.
I think we could just upload a new version.
There's a different way to do it. So how long are you waiting? What time are you working till today?
I was gonna stay till 4, but if I need, I can stay longer.
Let me see how long that this, we do like a debrief meeting afterwards. If it doesn't, they've been getting shorter and shorter. If not, let's hop on Zoom and then I'll show you how to update a file within Box without having to like download and re-upload and all that.
Nice, because then it'll keep that original file, right? So then we'll know like what used to be on there. Cool.
Yeah, so we'll do that. And then, yeah, see, there's all these little things that I'm like, we need to go over them at some point. We'll get there. It'll be fine. Oh, also, Calvin, you can bring them back at 3:25.
Okay, sounds good.
I just saw your Slack and like, it's just us three.
Is there anything else that you want me to be working on while I'm waiting?
Ask Vanessa about that smart sheets thing.
Okay.
Let's do that. And then if you need if she asks if she needs to like hop on Zoom with you, you can hop off this and go talk to her.
Okay, cool.
Yeah, because I think let's just say we're good with iEcho data for right now. Let's go with that.
Okay.
I'm going to request them back.
Here they come. Okay. Thanks, Calvin, for putting that together so smoothly on such short notice.
Oh, of course.
All right. It looks like we have everybody back in the main room.
I just wanted to put in a plug. I know we got cut off in the middle of a discussion, and I'm sure the other groups probably did to some extent as well. We will wrap up our formal session here in a few minutes, but we will stay on as usual, and we would love to continue the discussion. So anybody who didn't get to participate in the small groups, or if there's a topic that we should delve deeper into, we will stay on past 3:30, of course, and would love to have the conversation going on. But for the time being, we will hand it over to Christina to do her QI minute.
Oh, okay. We're going to move into the QI minute. Great. That means I can let Carolyn off the hook. She was going to have to give our themes from our breakout room, but that's okay. We can do the QI minute. You want to do the QI minute, or do you want to do themes?
How about we do themes after the QI minute, so that if people need to get off, they can, okay. but we'll stay on and encourage people to stay on with us.
Okay, nice last minute pivot. All right, I will bring this up. So truly in a minute this time, one of the things that I wanted to just share with you is how you might be able to take something that you would consider an opportunity for a performance improvement project, like, let's say, looking at virtual or window visits, and turn it into a PIP. And really it boils down to all of the frameworks are like 5 basic steps. Getting curious about the problem, observing it, talking to staff about it, mapping it, diagramming it, brainstorming it in terms of root causes and what we know, accessing any measures you might have available, but really getting a sense of what is the issue, what are some of the component parts, and what do we know and not know. Based on some of that curiosity and getting some of that background information, we move to step 2 around setting a goal around what we would like to be able to achieve. From that goal, we decide on what we want to try. We try it in step 4, on a small scales to begin with, 1 day, 1 resident, gaining, going up in scale with those tests as our confidence grows. And then we look to how we might be able to measure our impact in ways that make sense. So this is not like 15 measures that look at everything in our facility. It's a few key things that are going to let us know whether or not what we're doing is making a difference. So how might this translate if we've got to focus on, let's say, trauma and isolation? So in our curiosity step, we might be looking at asking how our staff or residents are feeling, thinking about what are some of the current efforts that we have around social isolation or trauma, and what difference they're making. Thinking about what could be better. Maybe we're going to employ something like a fishbone diagram. Maybe we're going to do it through huddles with staff, maybe a combination. Once we feel we have a good sense of what's happening, and that often is something that's ongoing, we are looking at what might be a reasonable goal for our facility. So we might be looking at having all residents have at least 1 meaningful, and we have to define meaningful, virtual or window visit with a family or a loved one once a week. Or maybe we want to make sure all of our staff are feeling heard and supported by the end of this month. What can we try? We can look at improving our virtual visits. We can look at staff huddles. We can look at some of the ideas that have been presented as part of this work and work that you already are familiar with through huddles or psychological PPE, or maybe look at the PTSD screening that was mentioned in the presentation today. Once we have a sense of what we might want to try, we then pick a specific test. So there's an example that if you listen to the video they gave around how might you improve a virtual visit for a resident with a loved one. And they talked about, do you have a discussion guide to deal with lulls in a conversation, so that if the resident is not sure what to say, or if the family isn't sure how to engage, is the staff familiar with how they might be able to prompt discussion, how they might be able to prompt the resident, or to redirect if a resident becomes distressed during one of those interactions, or a family member becomes distressed during one of those interactions. So what supports do we have to make these virtual visits sort of meaningful and a positive experience? And then if we think about step 5, how we measure, we can measure how many residents are engaged in a virtual or a window visit once a week. We can look at staff absenteeism rates. We can look at simple things like a marble measure. So this is an example in the corner there where it's a simple, this is actually from the IHI offices before, well, when they were allowed to go to the office, where in front of the elevators, they had a jar and two little glass balls, and you just took a ball and put it in the jar if you had a good day or a not so good day, right? Happy face, sad face. Okay, infection control nightmare right now, I get it. But what might be some of the other options to consider around simple ways to just get like a pulse check for people, right? How's it going? Well, not so well. If more people are saying my day has not been a good one, how do we start to tune into that and figure out what we might need to do to support people in a different way? So that is sort of my QI minute. And so my suggestion for you for the next week is think about, what are some of the conversations, discoveries, observations that you've been having over the past few weeks and months, and what might be one area that you might want to consider around and using that performance improvement project approach versus the just do it approach, which is sort of that strategy we can use when we have high confidence, low cost, low risk, and high buy-in. And if you have an idea for a PIP, can you connect with a few members of your staff to ask their opinion on what you might be able to impact in this area? Or if you're not sure about if there's a PIP available to you, could you connect with some members of staff to find out what might be some key focus areas for you? And with that, I will stop my QI minute. And oh my gosh, it took like an extra 3 minutes. Apologies.
It's all good. That's why these sessions are actually built for an hour and a half. But to be respectful of everybody's time, I know you guys are all super busy. We're going to do our little wrap up and then stay on and try to get the themes from our small breakout rooms and see what comes up. So we have the usual poll that we would like you all to fill out, please.
And while you're filling out the poll, we invite you to join us next week, Wednesday, November the 11th. And the topic will be the importance of CNAs. And I want to put a plug out there. If your CNAs have any opportunity to join this, it is very empowering, informative. It is a great talk.
The usual housekeeping in the chat with the links to the compensation packet, Higher Logic, where all these videos are easily available. We put the links to the video and the presentation PowerPoint in the chat as well. But if you have access to that Higher Logic, then you don't have to try to save it out of here. Case submissions, we're always looking for cases. We would love to discuss what's going on in your specific facilities. And of course, our email address is there. And with that, if you need to leave, please do so. But if you don't, we would love to hear from Carolyn about what the themes were in your breakout room.
We didn't really have much, but I think we all agreed that people were having problems with social isolation. With I was specifically my facility, we've kind of 50-50. Some residents are fine because they're happy laying in bed watching TV, and other ones are missing their families and forget that they've seen their loved one 5 minutes before, whether it's through a window visit, through a compassionate care visit, through a tablet or whatever. And I think everyone's just kind of trying their best to meet the needs of the residents, but it is a struggle. Is that about it, Christina? I think. Yeah,
and then there was a couple, Teresa had shared a couple of ways in which they're trying to deal with that around concierge support people, and a program they call Guardian Angels, support staff and residents as well. Thank you, Carolyn.
We didn't talk about who would report back from our little group. We didn't quite get to that, but does anybody feel comfortable talking about some of the themes that came up in our discussion? Wendy or Cynthia? Who else do I see still on? Nikisha? Okay, that's okay. I don't want to put them on the spot, but the things that came up is we did have a couple of facilities who do have a formalized screening process in place that they're using for the residents, a PTSD kind of screening, and they do have access to social work consult and a psych nurse practitioner as well. And then they were thinking about how to apply this to the staff now after having this discussion. Another facility reported back that they do have staff counseling available that they're using regularly, and that they were actually encouraging their staff members to use PTO for kind of mental health days, not just for sick leave. And then in another facility, we talked about combating social isolation with more kind of one-on-one activities, while also trying to maintain a sense of normalcy for the residents. So kind of one-on-one activities are not usually normal for the residents. So trying to balance that with the need to still interact with someone, even if it's not in the group setting that these residents are used to, and trying to find that balance. Anyone from my group, if you want to chime in, if I missed something, please do so.
This is Cynthia from ECHO. I just wanted to mention that we also discussed about if they're seeing any behaviors that are manifesting themselves now with this social isolation, meaning increased agitation or wandering, and what they're doing potentially to curb that. And also if they're tracking medications, PRN medications that they're using for that. And they all said yes, that they are doing things, but there's some ideas that they had about one-on-one activities with residents, hallway activities such as bingo, doing marching bands, and those types of activities.
In our breakout room, I'm wondering if anyone still on the call would like to give a summary of the things we discussed. And that's okay. In our group also, I think about everyone said that they have noticed an increase in medication use for increase in behaviors, be it depression, agitation, insomnia being another big one. And then screening of the residents, an increase in depression as well as antidepressant use. And this was at Linda's facility, and followed up with increasing their telehealth for counseling, and that has already made an improvement in the medication use. Not many facilities, and I think that probably is all the way around, not many facilities currently screening specifically for PTSD in staff or residents, but it seemed like something that could be implemented. What else? Yep, that's what I got. Did I miss anything? Group. I'm looking at you, Michael. You're still muted. Okay. Ooh, yeah, that definitely counts.
Carolyn, are you doing that for residents or also for staff?
No, that's for residents, but it didn't even occur to me to do it for COVID. This was something that's mandated that we have to do for all of our staff, our residents. And I think it goes back to previous things that might trigger back in the past, not so much a recent yeah, it didn't even occur to me that we are doing that, but I don't think we're doing it. We're doing it on every single resident, but not as a response to this. So, but yeah, it would. Everyone had some great ideas, so I didn't even think about some of those things.
Thank you for sharing. Wendy and Donovan, I noticed you had the thought.
Right, you know, and I was going to follow along with you, Carolyn. You know, like she said, it was a CMS mandate that we do the trauma-informed care. You know, it's just on initial admission, but we've been talking more and more about doing it with our quarterly assessments because of this pandemic. And, you know, I think it's going to be a more positive effort. Yes, it's a little more labor intensive, but I do feel like we should.
Thank you both for sharing that. It sounds like that may be a tool that is available at all the facilities, and sounds like there might be some good use for that in this current pandemic in ways that none of us maybe have thought about. But certainly the situation is certainly traumatic, and it's causing psychological distress for all of us. So that certainly counts as trauma. You know, that is something. This is something that is going to affect how we live our lives, how we interact with others, how we interact with our staff and our residents. And I think it's important to remember that we need to take care of not just our residents, but our staff and ourselves as well. So thank you for all those wonderful ideas that were brought up today.
So this is Cynthia really quickly. We talked about a little bit, touched on behaviors of the residents, but I'm also wondering if you all have noticed behaviors with staff. So normally when you see burnout and or any trauma with staff, you'll see like an increase in call-ins from maybe staff members that didn't in the past. So I'm just wondering if you're seeing any behaviors and how you're addressing those.
So for our facility, I mean, we went through an outbreak. So I have a lot of staff that cry easily or get really angry easily. And I just kind of like let it go and don't take it personally, because sometimes we do really try to make sure people are taking their PTO. I only have one other nursing supervisor that's with me. So it's myself and the infection preventionist who's also doing MDSs. And she went through, I was on quarantine during our outbreak. She was here in the front lines. And I don't think I have PTSD, but I know she has PTSD. And so she's usually on this call this week. She took the week off. And I said, yeah, you need to do that. So we're trying to take turns, the two of us, of one of us being here and one being off. I do see it in other departments because we're a large facility with independent living and assisted living. And I see it from other departments that had did not have the outbreak, but just the COVID fear in the community and fatigue, that they panic easily. And so we just have to kind of cut each other some slack and give each other some grace. And I mean, I see a lot of, I would consider more behaviors from people outside my department. My people, it's more making sure that they take the time off, they're well rested. And for the most part, I think we're doing that okay.
Thanks for sharing.
There's certainly a lot going on, and we really appreciate everyone who was willing to share some of the really difficult things happening at your facilities. I think that really contributes to this community that we're building and trusting each other and remembering that this is as safe a space as we can make it, but mostly it's a brave space, right? Where we can bring our concerns and not face judgment and just get support from one another. So thank you to everybody who shared today and who gave ideas and suggestions. I want to leave the floor open if anybody else wants to, if there's anything else that anybody wants to get off their chest or wants to get some advice or help with.
I'll make one other comment regarding the gentleman that was talking about doing counseling, but finding it hard for himself. So I went out for counseling for something personal, and I did that last year. And sometimes it's okay to seek outside help. And a lot of organizations have an EAP program, and just because I can listen to people and I can be a support for people, it's hard for me to do that for myself. But having an outside person who doesn't know there, I mean, the counselor that I was going to, I could tell her everything and I could just be myself and there's no judgment. And it really was helpful. So so don't feel ashamed if you need to do that. I know many people who, doesn't mean that we're not strong. It just sometimes it's nice to have an unbiased outside person who doesn't know, and there's no judgment. So don't feel bad if you need to do that, because it took me about a year and it did really help me, but it was something unwork related that was personal, but yeah.
Thank you for sharing that, Carolyn. And Avinash says thank you as well. Yeah, I agree. I think that's self-care is not selfish, and there's no shame in seeking. And I think, like you said, someone who has no judgment, but I think also someone that you don't have to play any role to, right? Like you're not their sister, you're not their mother, you're not their friend, right? And so you don't owe them any strength, I guess. So you put that beautifully.
Before we sign off, I just wanted to mention, I know that I can't remember who stated this, but talked about potentially starting the trauma-informed care assessments, including them in your quarterly assessment. It would be interesting to know if there was a change from when they were admitted and then at the quarterly assessment. So I was just wondering if, we would like to hear about that and what you implemented if you see that did occur.
What a great example of tracking data over time, Cynthia. Looking at the percentage of residents that show a difference in their trauma assessment after a quarterly assessment. Just the same.
All right, I think we can wrap this up formally now. We really appreciate everyone who stayed on, who shared, who participated, who listened, and maybe took away some ideas that you hadn't thought of before. It was a really great discussion today. I think there were some really heavy topics, and I feel privileged to have been able to participate in this with you all. So thank you for joining us today, and we look forward to seeing you next week.